is Lisa McKenzie with the Health Effects team.
Okay, so I don't have anyone to introduce that's here, but I am part of a team from the Colorado School of Public Health working with John Adgate, Ben Alshouse, and a few of our students up there. And before I start, we don't have any results yet. I'm going to tell you what we're going to do. Okay, so 7 out of every 100 Coloradoans live within 1 mile of a well that's been drilled since the year 2000. Several of these people live in Greeley, Colorado. The blue circle denotes a well site in Greeley, and you note the school and park around that. And the setback distances in Colorado are required to be 500 feet from a home, 1,000 feet from a school. And these setback distances were not based on any health data, and we really know very little about the health effects associated with oil and gas development. So what we're going to do is a human health risk assessment. In addition to considering chemical stressors, we're also going to consider other stressors such as noise and crime in these areas. Now, human health, for there to be a risk to human health, there need to be 3 components present. There needs to be a hazard, there needs to be an exposure to that hazard, and there needs to be a vulnerable population exposed. Also, when we look at hazards, all the different processes in the supply chain of natural gas development have different types of hazards associated with them. For example, diesel emissions are a hazard at many of the processes, whereas things like benzene are likely just a hazard during well development. Another thing that how hazardous something depends on is its dose or its concentration. The higher the dose on the horizontal axis, the more effect you have, as shown on the vertical axis. It also depends on where you are, the hazard. If you're very close to the site, you may be exposed to hazards such as benzene and silica. If you're further away from the site in the region, your hazard may be ozone, and at a global level, methane may be a hazard. Now, you become exposed to these things through breathing air or drinking water that's contaminated. You can also be exposed if you're sharing roads with trucks and things like that. So what we'll be doing is taking data that's been collected by the air and water quality teams and other studies ongoing in Colorado right now, and using that data in our human health risk assessment. We will consider the age of the population, whether they have chronic health conditions, race and socioeconomic status, because these can all affect how you respond to an exposure and hazard. Children and the unborn may be the most vulnerable. Risk assessment results are usually presented in 2 separate results. The first one are non-cancer results. These are anything that does not cause cancer. Then there's the excess lifetime cancer risk, and that includes all things that cause cancer. Back to the dose response curve, what we start with for the non-cancer is that point where we don't see any adverse effects in animal studies. There are some human studies, but these are fairly rare. Most of the things are done on animal studies. And since they're done with animal studies, and animals and people don't respond the same way, and because people themselves can respond different ways, we divide that least observable effects level with uncertainty factors to come up with a reference dose or a safe dose. We then compare the safe dose to the concentration someone was exposed to. If the concentration someone was exposed to is greater than that reference dose, we conclude a health effect may occur. If it's less, we conclude a health effect is not likely to occur. For the cancer risk, we also use animal studies, but no safe dose is assumed. What we do is we calculate how many in 1 million people are likely to get cancer if exposed, and compare that to 2 thresholds set by EPA. The first one is their minimal threshold, and that's 1 in a million people would get cancer if exposed. Their high threshold, and where they start to consider the risk to be substantial, is if 100 in a million people are predicted to get cancer. In between these 2 levels is the communities and regulators figure it out at that point. Now, just to keep in mind, 400,000 in every million Americans are predicted to get cancer in their lifetime. So this excess lifetime cancer risk that we're calculating is in addition to that. Finally, at the end of the risk assessment, we sum up the hazard quotients for all the chemicals or other stressors we've looked at, and we sum up the cancer risks and compare them to the same thresholds. And that is risk assessment in a nutshell.